Dermatoses due to plants, a clinical perspective. Good day, everyone. Imagine this: a patient walks into your clinic with an intensely itchy, blistering rash tracing an almost poetic, linear pattern on their arm. The culprit? Not an infection or an autoimmune disorder, but a simple, unassuming plant-induced dermatoses, while often overlooked, are a significant part of dermatology. These conditions can range from mild irritation to severe allergic reactions that closely mimic other skin disorders. They demand precision in diagnosis and management. Today, we'll journey through the fascinating world of plant-induced dermatoses, unraveling the mysteries behind their botanical origins. Clinical presentations and effective management strategies. We'll dive deep into the story of poison ivy, a plant so notorious yet so misunderstood, as well as others that can leave their mark, literally, on our skin. Botanical aspects of plant-induced dermatoses, binomial nomenclature, the Latin key to precision. To truly understand plant-induced dermatoses, we must first appreciate the botanical science behind them. Every plant has a unique Latin name, a binomial identifier. This system helps dermatologists and botanists speak the same language, avoiding confusion over plants with multiple common names. For instance, poison ivy is scientifically known as Toxicodendron radicans. Poison oak becomes Toxicodendron diversilibum, and poison sumac, Toxicodendron vernix. This clarity ensures we diagnose and manage these conditions accurately. After all, calling a rose by another name might smell sweet, but calling poison ivy by the wrong name could lead to mismanagement. Plant identification, a necessary skill. Let's now focus on identifying toxic plants, a skill vital for prevention and education. Here's how you recognize the usual suspects: poison ivy, Toxicodendron radicans. Look for 3 leaflets with smooth or slightly serrated edges. In autumn, the leaves take on a striking reddish hue. It can grow as a climbing vine or a shrub. Poison oak, Toxicodendron diversilibum. These leaves resemble those of an oak tree, hence the name. It grows as a shrub or climbs like ivy in certain regions. Poison sumac, Toxicodendron vernix, a taller, more tree-like plant with smooth-edged leaflets grouped in 7s to 13s. Failing to identify these can lead to unnecessary exposure, or worse. Misinformed advice. Poison ivy, the persistent allergenic threat. Poison ivy is infamous for its allergic potential, courtesy of urushiol, a potent oil within its sap. Fun fact: despite its benign-sounding name, poison ivy remains a formidable allergenic plant even after being reclassified as Toxicodendron radicans. Urushiol is so tenacious that it can remain active on surfaces like clothing or pet fur for months. Even indirect exposure, say, through a beloved furry companion, can set off a reaction. Etiology of plant-induced dermatoses. Plant dermatoses arise through various mechanisms. Let's break them down. Irritant contact dermatitis, ICD, a direct, non-immune chemical irritation. Common irritants include calcium oxalate crystals found in plants like Dieffenbachia. Allergic contact dermatitis, a delayed type hypersensitivity reaction, mediated by T cells. Key culprits include urushiol, Toxicodendron species, and sesquiterpene lactones, Parthenium hysterophorus. Phototoxic dermatitis. This occurs when psoralens in plants like Citrus bergamia react with sunlight, causing blistering and pigmentation changes. Mechanical irritant dermatoses. Think spines, hairs, or thorns, common in plants like cactus or urtica species, causing linear scratch or granulomas. History and clinical findings. The role of history. A detailed patient history is a dermatologist's compass. Did the rash follow outdoor activities like gardening or hiking? Was there direct contact with plants, or was it indirect, via clothing, tools, or pets? How soon did symptoms appear? Allergic reactions often have a delayed onset, 12 to 72 hours after exposure. Occupation and hobbies provide clues. Farmers, landscapers, and outdoor enthusiasts are at higher risk. Clinical presentations. ICD rapidly develops after exposure, presenting with erythema, burning, and scaling at the contact site, ACD, intensely itchy, erythematous vesicles often form streaky, linear patterns. Phototoxic dermatitis, painful erythema and blistering occur on sun-exposed areas, often leading to hyperpigmentation, mechanical dermatitis, scratches, punctures, or granulomatous reactions from plant spines. Diagnosis, decoding the clues, clinical examination, look for characteristic patterns, like linear streaks and poison ivy dermatitis. Patch testing helps confirm allergens like urushiol or sesquiterpene lactones. Wood's lamp, useful for detecting phototoxic reactions. Biopsy reserved for atypical or chronic cases. Histology often reveals spongiotic dermatitis with eosinophilic infiltration. Management, general principles, avoidance, teach patients to recognize toxic plants. Gloves and barrier creams are lifesavers. Decontamination, wash exposed skin and objects with soap and water immediately. Time is crucial to remove urushiol. Treatment algorithms, mild to moderate dermatitis, topical corticosteroids, clobetasol 0.05% for 7 to 14 days, triamcinolone 0.1% for sensitive areas, antihistamines. Cetirizine 10 mg daily or hydroxyzine 25 to 50 mg at bedtime, moisturizers, calamine lotion or zinc oxide for soothing relief, severe or extensive dermatitis, systemic. Corticosteroids, prednisone 0.5 to 1 mg/kg/day, max 60 mg per day, tapered over 2 to 3 weeks. Oral antihistamines, loratadine 10 mg daily or diphenhydramine 25 to 50 mg every 6 hours. Wet dressings, Burroughs solution for oozing lesions, infected dermatitis, topical mupirocin or oral cephalexin 500 mg every 6 hours for 7 days if secondary infection occurs. Phototoxic dermatitis, sunscreens, SPF 50 is non-negotiable. Topical corticosteroids, low-potency steroids for short periods. Hydration, encourage fluid intake and emollient use. Prevention, the ultimate cure. Education, teach patients to identify toxic plants and avoid exposure. Barrier creams, products with bentaquatum are effective against urushiol. Proper decontamination, ensure all clothing and tools are thoroughly washed. Conclusion, plant-induced dermatoses are common yet preventable. Through education, early recognition, and evidence-based treatment, we can help patients navigate these conditions with minimal discomfort. By bridging botany and dermatology, we empower ourselves to provide better care for those impacted by nature's hidden threats. Thank you. Let's open the floor for questions and further discussion.